Good evening, everyone. I am Ada from IJCP. I extend a very warm welcome to all our esteemed doctors and participants joining us for today's live session. A very warm welcome to all the respected doctors and speakers. Today, we focus on a topic that sits right at the intersection of endocrinology, cardiology, and metabolic health. Cardio-Metabolic Crossroads, managing the triple threats of diabetes, hypertension, and obesity. This triad is become increasingly common in our clinical practice, leading to higher cardiovascular risk, earlier complications, and a heavier diseases burden. Understanding how these conditions interlink metabolically, hormonally, and vascularly is essential for effective prevention and long-term management. So it is my honor to introduce our speaker for this session, Professor Dr. Ramamurthy Bingi, sir. He did MD in medicine, DM in cardiology, interventional cardiologist, Bingi's Heart Care and Fertility Center in Bangalore. Dr. Bingi is a leading cardiologist known for his deep expertise in cardiometabolic diseases, preventive cardiology, and intervention care. His understanding of the metabolic cardiovascular continuum makes him the perfect expert to guide us through today's discussion. With great pleasure, I would like to hand over the session to Dr. Ramamurthy sir to take us through the scientific insights and clinical pearls of this important topic. So this is over to you. Thank you.
Thank you, Afseen. It's a wonderful talk that today you have organized. I am really thankful to IRCP. Today's topic is, as she puts it across, is what is called as a cardio-metabolic syndrome. You may think, what is this syndrome, new syndrome that is emerging up in the cardiology field? Yes, we are now going through a spectrum of metabolic endocrine diseases, which are all linked to the cardiovascular morbidity and mortality, cardiac diseases in various manifestations of atherosclerosis as well as heart failure. So here the three prongs of the syndrome include diabetes, hypertension, and cardiac disease. Are we at the crossroads and how to manage them? Both the therapeutic front and as well as the preventive aspects. Can I have the next slide, please? This is not such a new name, but anyway, there have been earlier time we have been talking about the so-called metabolic syndrome. Some people had even coined the term like cardio-diabetology, diabesity, when there is a combination of diabetes and obesity. Cardio-diabetology is a quite a common term among the physicians involving both the heart diseases, particularly the diabetic subset of population. And the metabolic syndrome is also quite frequent, but we don't really, many of our physicians and cardiologists are hesitant to make a label in their day to day practice because to start with, they didn't have the recognition by the World Health Organization community. But we know that what the metabolic syndrome is, the real burning topic today is the combination of these various metabolic syndrome aspects. So it is an old disease entity, but we have given a new name because there is a cardiovascular morbidity and mortality in which various spectrums is quite high. And that is how we have to look at this as a cardiovascular disease rather than a separate entity of diabetes or gastroenterology and the like. So that is the reason why we have to concentrate on this cardiometabolic syndrome. Next slide. What are the definitions? What are the components? We do not have significant, definitive diagnosis or definitions available. What we know that is the cardiovascular disease in various manifestations, combined with the metabolic elements like obesity, metabolic syndrome, type 2 diabetes combined with constitutes the cardiometabolic syndrome. Why this entity is being taken and talked in a separate way? Because it says the same pathophysiology and the clinical consequences are mostly on the cardiovascular system, and the treatment as well as the prevention is at crossroads in the sense it's a shared area, shared platform by the physicians, diabetologists, endocrinologists, cardiologists. Particularly now, we cannot shun away in treating the diabetes or preventing to see that the diabetes doesn't happen. And thus, this area is becoming more and more a common field where everybody should be interested. Next slide, please. The fundamental issues in this cardiometabolic syndrome are there are multiple biochemical and hormonal abnormalities present in this basket. This particular entity carries an high risk, particularly in IHD. Everybody knows that metabolic syndrome carries almost twice the mortality for an acute coronary events, both unstable and an acute myocardial infarction. So it cannot be taken lightly. It's a separate entity having its own significance. And in the practice, we have not known not only in the day-to-day examination of the cardiac patient, but also in the preventive health checkups. Often there is a combination of impaired glucose or postprandial glucose. There is then lipid abnormalities, and there is often a borderline hypertension or even a definite hypertension. This sort of a clustering is there. So it becomes very easy to make a diagnosis of metabolic syndrome. And here we have included obesity part also, particularly the measurement of the BMI. Some even accept it as an abdominal girth, hip abdominal girth ratios and all. But basically the definition components are varying from various uh, medical boards, including Hypertension Society, Preventive Society, ACCHA guidelines, so many things. But fundamental appears to be the obesity, hypertension, diabetes. These are three fundamental, along with peculiar lipid abnormality in the form of increased triglycerides and low HDL values. The presence of an elevated insulin or abnormal glucose tolerance, all of them are varying from one body to other body, but they are also not equally important in making a diagnosis. How did we recognize? Why did we recognize entity as a separate one? Because we have seen that we have managed the blood pressure very, very vigorously. We have trying to prevent the acute cardiovascular events, and then the various risk factors in the form of hypertension and diabetes. In spite of it, there is a significant amount of residual risk. Just managing hypertension doesn't in any way end up there. Similarly, trying to bring a patient's blood sugar to the target of less than 6.5 or 7 doesn't end there. Still, the patients are trying to uh, die, and this makes us to become one aware. There are many other aspects other than the simple major risk factor alone, which we are to really look into that. And here is the crux of this so-called cardiometabolic syndrome. And this particular entity became more and more important when we started recognizing the diastolic heart failure. You know, 50% of the heart failure patients are diastolic, comparison with the reduced EGF of 50% of the cases if you take. And in the diastolic heart failure, fundamental point we always talk is they have often combined comorbid diseases in the form of hypertension, atrial fibrillation, diabetes, age factors, so many things, IHD background. So that indicates that there may be something as a phenomena other than the simple blood pressure part, other than the simple sugar part, which may be responsible for these clinical manifestations. And that is where our eyes started opening and thinking comprehensively of the so-called cardiometabolic syndrome. Next slide, please. The various pathophysiologists are there. The many people think about the shared metabolic pathways. This may be shared systemic inflammation and generalized inflammation, and it may be even a local inflammation also. And we are also talking in terms of the so-called inter-organ crosstalk happening between the organs, systems like between the heart and the liver, or the liver and the other organs. And the knowledge, particularly recently, that we gained by the use of two group of molecules in the management of diabetes, they opened our eyes. They are not simple drugs which are controlling the sugars, but they have beyond sugar control. They have a benefit in terms of reducing the cardiovascular morbidity and mortality. And this has opened our eyes that there is something else that is apart from the simple risk factor management that is important. That is the metabolic endocrine component of the cardiometabolic syndrome. Next slide. The cardiometabolic syndrome doesn't end with these three components, but there are also many other things that we have recognized. Often these patients have fatty liver, they have obstructive sleep apnea syndrome also. It suggests that possibly when you are suspecting an obstructive sleep syndrome, or in a patient who has come with a report of an ultrasound saying that there is a fatty liver, we should be thinking seriously of the so-called cardiometabolic syndrome. Next slide, please. The ultimate problem happens is in the cardiovascular diseases, whether it is a metabolic component or it is an endocrinal component. They are not the overall driving points. It is the cardiovascular deaths that often happen. That is the reason why it has become a very important sweet topic for the cardiologist. Next slide. Now, among these various things, particularly in the last few years, the attention has focused on the so-called obesity. We know that even in a day-to-day practice, we have seen that the patients are observed that the obesity is quite rampant in our daily life. We do often see that the patients do have obesity obviously seen. No, in Indian setup and Asian setup, we often see that there are something like ponderal obesity. It's a very, very minimal obesity that is obviously seen from above, but there is a significant amount of fat in the abdomen. And for example, if you really go through the Western literature, you see that almost um, 50 to 70% of the patients do have obesity in one form or other, and that has become a burning issue in the socially developing countries. And the people then thought that it is overall excess fat that is not important, it is the visceral fat that is important. That is what how they said it. The definitions have been varying, and BMI, some people take it into consideration, some people take waist hip ratio, some people take only the waist ratio, waist measurement. Some even take an measurement taking into consideration waist divided by the height of the patient. Whatever it is, the definition appears to be. If there is more than 20% overall ideal body weight, more than that weight, it is considered as obesity. I'm not going into definition of various mild, moderate, morbid, and all that. It is understood obesity in any form is abnormal, and it is having implications not only heart and many other organs also. And fundamental all over analysis in the preventive cardiology segment, appears to be because of unhealthy lifestyles and food habits. And the significance lies in that obesity leads on to metabolic syndrome, it leads on to diabetes, hypertension, dyslipidemia, and cardiovascular disease. The implication appears to be in terms of obesity, diabetes, obesity, hypertension, obesity, cardiovascular disease is a sort of a multi-directional impact with a more or less reciprocal interaction. That is why we should not neglect obesity to just an endocrinologist and or in a dietitian part. We have to take very significantly and this particular point and manage them. Implications are both hemodynamic, metabolic, and as well as inflammation. And the preventive aspect is concerned, just like we say that even a 5 millimeter drop in the systolic blood pressure reduces the cardiovascular mortality. Like this, even patients lose 5% of the overall weight, there is a decrease in the cardiovascular morbidity mortality. So that is how the scientific community has started looking very seriously on the role of obesity. Next slide, please. We have various hypotheses. How does this obesity produce a problem? It produces probably because of the so-called neurohumoral substances that are produced. Adipokine hypothesis is there. There is an excessive adipokines or abnormal leptins, and there may be a dysfunctional fat cell hypothesis also. The cell becomes filled with the fat and it expands and then it becomes transformed from a storage cell to an active secretory cell. And inflammation, abnormal metabolism, or oxidative stress, all of them are interlinked. And that is responsible for the various clinical manifestations. Next slide. Is there a necessity of assessing obesity? I don't think so, but we should know, other than the simple anthropometric data, there are some studies have been done in quantifying it by CT and MRI studies, but these are all not routinely recommended. Next slide. Diabetes is concerned, everybody knows. I'm not going to dilate upon that. Once I was interacting with one of the diabetologists. It is a real statement. It is comprising of two disease elements actually. One is a metabolic element. Probably that was the one when we were studying at the MBBS level. We were talking about hyperglycemia, ketoacidosis, hypoglycemia, amputations, and the like. Later on, we noted that there is a vascular components are more important, particularly cardiac and less frequently peripheral vascular manifestations. And of course, the glucose is bad and its metabolites are abnormally bad. High insulin levels are also necessarily important. Dyslipidemia, hypertension, which often accompany, all of them do produce vascular damage and injury and cardiac manifestations. Next slide. And then we have understood the simple concept which have been talked loosely apart from these medical components of the metabolic syndrome and cardiometabolic syndrome, that is about the insulin resistance. And we should know that it is the beginning stage of a type 2 diabetes or even in a pre-diabetes. Later on, this becomes progressive and it leads on to the pancreatic cell, beta cell exhaustion. First, it starts as the resistance, later on, it becomes a total deficit of insulin from the pancreatic cells. Next slide. The fundamental pathophysiology, as we go through all of this, appears to be an inflammation of the blood vessels, particularly endothelium of the arteries, and which in turn produces endothelial dysfunction and various cardiovascular manifestations. When we talk about the endothelial dysfunction, I was just going through one of the editorial. It was saying that endothelial dysfunction, we know about diabetes, we know about hypertension. What about the organ wise? If we say, if you take at the heart level is concerned, They say the fat cells that are surrounding the blood vessels in the heart, they themselves become abnormal and start producing inflammation components and immune components that is responsible for the vascular damage. So it has got both a paracrine effect as well as the systemic effect. These various substances should not be kept lightly. So inflammation is one component and oxidative stress is another component, all of them producing an endothelial dysfunction and vascular disease. Next slide. The importance, as I said in the beginning itself, is because it's the leading cause of death. There is a high prevalence in economically advanced countries like USA, and it's rising in prevalence in low and middle class groups in developing countries. Even in India and Southeast Asian countries, the prevalence appears to be almost about 25 to 30%. Is not small. I can say 1 in 3 patients. CVD treatment and prevention advances are not keeping in tandem with the management of metabolic diseases. Now we are recognizing that we are managing hypertension, diabetes, but still the cardiovascular disease mortality is happening because there appears to be something else has to be done. That is where our attention should turn. That is not looking at the isolated disease entities, but looking at the metabolic and endocrinal aspect of the disease. Next slide, please. We also know this is a truth, in fact, in our day-to-day practice. If you take hardly about 10% of the population is really healthy in terms of having a normal weight, no blood sugars, rise in the blood sugars, normal blood pressures, normal BMI, and normal lipids. That means 90% of them are sick in one component or the other. And this makes us to think that we should try to give them significant, open our eyes in terms of management and as well as prevention of this entity. Next slide, please. There is a need for a comprehensive management either in the cardiology or as a multidisciplinary approach. Next slide. Whom should you target? There are many a times we do pick up them by routine clinical examinations or even health checkups. Above the 45 years, we should target everybody for a health checkup. And in our country, it should be reduced to less than 35. Family history of heart disease is there. Overweight, sedentary lifestyle, smoking, excess alcohol, and they have also been known to have hypothyroid issues or they have been detected to see that they have high TSH values and in all of them PCOD problems we should try to investigate. Next slide. There are some people who say that apart from the clinical anthropometric this thing, we should try to look at inflammation component, which is we often recommend a high sensitive C-reactive protein, and even some of the uh, scientists they do recommend that we should examine for abnormal insulin resistance or elevated insulin levels, but they do vary from stage to stage, and they are costly tests, and we don't do them. But high sensitive C-reactive protein is slowly emerging as an important test, though it is costly into our day-to-day examination part. Next slide, please. Next slide, please. There is a, other than that, just where a platform of the doctors were discussing our role, but there is a significant role by the society, by both the people as well as government also. And in some of the places, even they have started special clinics, cardiometabolic clinics, which can concentrate on this group of patients. Next slide. We have various drugs that are there. Earlier, we started with the biguanides. SGLT2 inhibitors and GP1 receptor agonists have could become up in a big way. All these years, we didn't have any drugs which showed the cardiovascular mortality benefit in terms of oral hypoglycemic drugs. slowly metformin emerged in a big way. And we have started off with the use of drugs like SGLT2 inhibitors in the management of diabetes to further reduce the HbA1c. But later on, we made out there are so many other advantages in terms of reduced cardiovascular morbidity and mortality, overall control in hypertension, overall control in the weight. And that is how we made out that there are many drugs which are probably acting metabolically and endocrinologically, and that is how they have been showing an improvement on the cardiovascular morbidity and mortality. And in this last few years, the SGLT2 inhibitors have become a group of drugs very much accepted in the management of not only the diabetes, I mean, even non-diabetes, both in terms of heart failure as well as without heart failure as a preventive strategy. And of course, we have been listening a lot about GLP-1 receptor agonists, which started off as a treatment of choice for the anti-obesity management. And in fact, in the Western countries, it appears to be the number one drug that is being prescribed, but slowly it will catch up even in countries like India. And this drug, recently, some of the papers have shown, even in a non diabetic population, there is a significant non diabetic, non obese patients. They are significantly benefiting overall reduction of the cardiovascular morbidity and mortality, particularly in one of the paperwork where they had tested in a non obese patients and they found that it is highly beneficial. So these are the two group of drugs which have shown an immense benefit in the so-called cardiometabolic segment for disease management. We should keep them in mind and we should be able to use it both obese patient, non-obese patient, heart failure patient, no heart failure patient, diabetic, no diabetic. Probably here we may be pitching on apart from managing the lifestyle management in a significant number of patients by use of these drugs, particularly selected patients, will be benefiting them. Next slide, please. This has led on to an new group of thinking, what is called as the preventive therapy that can be applied. Uh, they are not started as a cardiovascular drugs. Apart from cardiovascular drugs that we have been all familiar with, statins, aspirin, clopidogrel, and the like, ACE inhibitors, we do have an important drugs that are beneficial in cardiometabolic syndrome. And slowly it has been one more buzzword that has been we are hearing is that we do talk about the so-called risk factors and their modifications. In spite of this, in 50% of the so-called cardiometabolic syndrome, the contribution of genes appears to be very significant. Probably we will be within a few years talking about the so-called the personalized medical care by trying to look at the overall components of the cardiovascular disease, apart from the metabolic component and endocrinal component and cardiac component, and trying to manage the patients in that three-pronged attack. Thank you very much for your patient hearing.
Thank you so much, sir, for such comprehensive and insightful session. Your perspective on managing the cardiometabolic triad have truly added value for today's program. So, with all your permission, sir, shall I take question one by one?
Sure, sure, Afshan.
Okay. So the first question we received: how does insulin resistance acts as a central link connecting diabetes, hypertension, and obesity in cardiometabolic disease?
Yes, so the fundamental thing appears to be the insulin resistance. And insulin resistance, as the glucose entry into the cells is abnormal, we have been recognizing there is an abnormality in the lipid metabolism. There is an excessive secretion of the fatty acids. There is an excessive secretion of the LDL particles, decreased secretion of the HDL particles. We have already recognizing this entity in our day-to-day practice in the form of what is called as commonly being talked about diabetic dyslipidemia, and even the sugars, high level sugars, they themselves are toxic. Metabolic products of the glucose have been recognized as toxic to the endothelial cells, and hyper insulin levels, because the cell is sick, the insulin levels go on increasing from the pancreas, they themselves make abnormal abnormalities in the cells, and that is how the disease progresses.
Okay. Thank you so much for this brief answer, sir. I hope you did justice. So, the next question is, what early clinical markers should physicians look for to detect rising cardiometabolic risk in asymptomatic patients?
In as I was trying to look at it, we should look in Indian population. Everybody is at a high risk of cardiometabolic syndrome, and this is particularly so if we are seeing male patients above the age of 35 with family history and even slightest ponderal obesity. First, you probably think of metabolic syndrome, and I have picked up a lot of metabolic syndromes in day-to-day health checkups, the so-called general health checkups. I make out that the patients have fatty liver, the patients do often have low HDL values, sometimes mildly elevated triglycerides, high uric acid values. All of them should make you to think that we are dealing with a metabolic problem.
Okay. Thank you so much for this brief answer, sir. So, the next question is, how do weight loss focused therapies impact cardiovascular outcomes in patients with this triple burden?
I think weight reduction is definitely going to help in terms of reducing the blood pressure. We know that simple weight reduction is the first component of managing hypertension, a non-pharmacological management of hypertension. We have seen up to 5 millimeter systolic, up to 3 millimeters diastolic, particularly when they start doing aerobic exercises and regularly dynamic exercise, it comes down up to 10 millimeter by itself. That is one side of the component. The metabolic components definitely do improve, and exercise has been shown. I think where there were some elegant studies which showed that the endothelial function, probably by overproduction of nitric oxide, improves. So there is an improvement in the endothelial function. There is an improvement in the blood pressure part. Of course, we know that diabetes management becomes easier if they start doing exercise, and the cholesterol values also decrease, and HDL value, which is a is a protective cholesterol levels, often increase. Triglyceride patients often become normalized, and this sort of an improvement is quite possible by the simple entity like regular exercise.
Okay. Thank you so much for the answer, sir. As I can see, there is only one question is left. So the question is, what long-term management strategy offers the best outcomes? Lifestyle first, pharmacotherapy first, or a combined stepped care model?
I think the lifestyle changing is the first and the foremost, and it will be the last one. It should be the first, and we should emphasize more and more. Unfortunately, here too many things are involved. We try to often say, okay, start doing exercise. He listens to you. The persistence of exercise program is not there. So that means motivation is not there. There is a need for other health personnel to help him to see that he continues to do that. And equally true, there is a need for the government agencies to create more and more spaces for the people to do the exercise. And we should also give education to them. It doesn't matter whether they have to, after the food they're doing or before the food they are doing, at least about 30 minutes to 45 minutes of exercise, even in the working space, also is important. That means it is a comprehensive and a persistent effort that should be done by both the doctors as well as the paramedical people and society people.
Okay. Thank you so much, sir, for this brief answer, sir. I hope you did justice with all the answers, sir. Sir, so with all your permission, sir, I am going to conclude this session, sir.
Thank you very much. Thank you. Thank you, all of you, for your patient hearing.
Yes, sir. On behalf of IGCP, sir, we express our sincere gratitude to all our participants and doctor for joining us today. Wishing you a healthy and wonderful evening ahead. Thank you and good evening.
Thank
Thank
you.
you, sir.